Before I talk, I'm just going to give you a little disclosure, which is the research today is based on a parent training curriculum that is published by Guilford, and I do receive royalties for the sale of the manual. So just let you guys know up front, I do have some, I guess I have to declare my conflict of interest. Also, some of the research I'm going to be talking about today was supported by an internal grant from Michigan State. So I want to acknowledge them in this as well. So I just wanted to start briefly with a little bit of an overview. What we're going to really be talking about is improving social communication in children with autism, but primarily with the parent-mediated intervention model. So briefly, what is parent-mediated intervention? This is a form of parent-therapist collaboration that involves systematic instruction and strategies that help parents accomplish specific goals or outcomes for their child. And in the literature, both in the area of autism as well as more broadly children with mental health issues, we really see parent-mediated interventions being focused in kind of three areas. One is managing children's behavior. So for those of you who are familiar with parent training or parent-child interaction therapy or the parent management training, some of these models that have been used with children with disruptive behavior or who are at risk for disruptive behavior. There's some fabulous interventions out there focused on training parents to be able to manage their children's behavior. The two that the area I'm going to talk about today are ones that we see more often in work with children with developmental challenges, which are to improve parent-child interactions and to help the parents help their children acquire developmental skills. So there are a number of benefits of parent-mediated interventions, particularly for children with ASD. One, as you guys know, children with ASD require an incredible intensity of intervention compared to children with other types of mental health issues. And in most public areas, it is very difficult to provide the level of intensity that children really need. So one real benefit of parent-mediated intervention is if we can increase parents' skills in providing therapeutic interactions with their child, we can really increase the intensity of intervention that a child receives. There's also evidence to suggest that if you teach parents how to use the intervention with their children at home, children experience better generalization and maintenance of skills because they're using these skills within the interactions in which that are most meaningful, in which they live most of the time. We also see some nice benefits for families. There is some evidence that parents that receive training in working with their child do have some reductions in some aspects of parenting stress, particularly as it relates to the parent-child system. And then finally, and this is it's unfortunate that we have to focus on this, but in today's day and age of trying to find funding, funding for these interventions, parent-mediated interventions are cost-effective. For 1 hour of therapist time, you can increase skills in parents and have a much broader effect than if you're just doing one-to-one therapy with a child. Now, all of these things being said, a number of different national organizations have reviewed the literature on parent-mediated interventions for children with ASD, and it's considered an evidence-based practice. Both the National Standards Project and the National Professional Development Center for ASD have reviewed it and considered it evidence-based practice. And they based this on an evidence base from a number of single-case studies or single-subject design studies that show improvements in parent use of the intervention strategies, so parent fidelity, child language, play, and joint engagement. And here I'm talking particularly about parent-mediated interventions focused on improving parent-child interactions and developmental skills. However, there's also a good literature to suggest that parent-mediated interventions that work on reducing problem behaviors are also very effective. And then more recently, we're starting to see some randomized controlled trials that have been looking at parent-mediated interventions focused on increasing social communication in young children with ASD. And a number of these recent RCTs have shown gains in parent responsiveness and associated gains in child joint engagement and initiations. So there's some promise here. However, there are also some non-replications. So there have been some recent RCTs that have been published that have not been as promising as we kind of hoped. So I think we need to keep that in mind. I think while it's considered evidence-based practice, and we should be doing it, it's very important to evaluate our models and understand how they're working, for whom are they working, given that they're not necessarily working uniformly across the board. So this being said, there actually are a number of promising interventions out there that have been designed to teach parents how to increase social communication skills in children with ASD that are in the kind of early developmental period. Some of these are ones that are probably familiar to you: Hammond, More Than Words, Responsive Teaching, the Play Project, which is a Michigan-based program which is based on a DIR model. PRT, I hear some people are doing PRT here. Actually, I worked with Laura Schreibman, who's one of the people that was a developer of PRT when I did my graduate work, so I have a very fond place in my heart for PRT. Enhanced Ability Teaching, Amy Weatherby's Enhanced Social Interaction Project, Early Start Denver model that has parent training component, and then Project Impact, which is what I'm going to talk about today. But what I want you to notice here is there are a lot of these programs that are coming out that all have some initial evidence base. They kind of are either developmental or naturalistic behavioral, or in some cases a blended model, which is what we have. But we also see some differences in how they're implemented, whether they're implemented in a group training or an individual format. And we also see some differences in the length of initial training. How long does the parent receive training, how frequent, etc. So there's quite a bit of variability, even though we have a number of interventions that are doing some similar things. So this being said, it's a evidence-based practice. It's recommended. In fact, the National Research Council recommendations that came out in 2001 suggested that it should be part of all comprehensive intervention programs for young children with ASD. And there are a number of promising interventions that are out there. So the big question is it making its way out to where it needs to be? How is parent-mediated intervention being used in the community? If it is an evidence-based practice, are we seeing it being routinely provided to families of young children with ASD? And the answer is actually it's highly underutilized in community settings. So there have been a couple surveys that have looked at, that have come out in the last 5 or so years that have looked at what services are parents accessing. And there was one study that was conducted in Indiana, that came out several years ago, suggesting that although parents actually ranked parent training as the #1 service that they received that contributed to their child's growth, it was actually one of the fewest access services among a litany of services. And then there was a study that came out of North Carolina more recently that suggested in children 4 and under, only about 8% of families were receiving parent-mediated intervention. So it's there. There's a good evidence base for it. There's really good reasons to be using it, but it's not really being used routinely in community settings. So one of the questions is why? And there actually are a number of barriers to parent-mediated programs being used in early intervention. And the literature's talked a little bit about what some of these barriers are. Some of you probably have experienced some of these barriers. We certainly have in terms of trying to roll this out. One of the barriers is sort of a barrier based on sort of what the provider's view is of their own versus the parent's role in intervention. So there are providers that really feel that parents are burdened enough with having to care for a child with special needs. If we're asking them to be a therapist too, that's an unrealistic burden to place on parents. Parents should be parents and providers should be providers. There's also some views that perhaps parents are not able to provide the level of service that providers can. So there's sometimes barriers just in terms of providers' willingness to consider this a service that they would want to provide. We also see, and this is very much the case, especially for providers who work with children aged 3 and over, limited provider preparation in how to actually work with parents. So people that have had training who are early intervention providers have usually had some training with this, but they're not usually trained in how to actually use adult learning strategies to train other adults. They have been trained in how to work with parents to develop a collaborative relationship, but not really how to provide specific coaching feedback to help increase parent skills. Once you get to be working with children 3 and older, there's almost no preparation whatsoever for how to work with parents. It's all about working with kids. So there's very limited preparation for our providers that are out there dealing with kids in specifically how to work with the parent end. So sometimes people feel uncomfortable and they say, it's just easier for me to work with the kids because there's great curricula around it. I've had a lot of training and experience. And then finally, especially when we think about where the majority of children with ASD are receiving services, most of them are receiving them through the public schools. Some of them are getting great in-home private therapy, but that's really a small percentage of our kids. So if we think about where most kids are getting services, once the kids get to age 3, where a lot of our kids with ASD aren't actually getting picked up before 3, which is crazy, but it's still the case, they're really receiving intervention mainly in a classroom setting. And most of the parent-mediated intervention models that I showed you are designed to be conducted one-on-one. And so when classroom teachers think about doing parent-mediated interventions, they think, well, how the heck am I going to do this in my classroom? I have, 3 teachers and 10 kids, and They're all there at the same time. There's no time for me to sit there and meet with parents, so I'm just not going to do it. And this is particularly problematic because actually when we look at the literature, the very best predictor of parent involvement in their child's education is how much teachers provide opportunities. So if we're thinking about getting parents involved in their children with autism's education, we need to think about models that can actually work for public classrooms where the kids are getting their services. So this is sort of where we come with Project Impact. This is a what I would call a blended model, blended naturalistic, developmental naturalistic behavioral intervention model that we developed a number of years ago now. It's been a long process. We started in 2004 or 5, and it got published in 2010, and we're still working on it, so it's been a long process. But this is a parent-mediated intervention model that was based on best practices. So basically, we looked to the literature to find what are intervention strategies that have an evidence base. So all of the intervention strategies that are in this curriculum have an evidence base from other studies or other interventions that have been examined. And then also there's a lot of literature on sort of best practices in working with families, adult learning strategies. So we pulled together from the literature those strategies that had evidence for them. So in many cases, the intervention strategies share a lot of similarities with other interventions. For example, PRT. There are PRT strategies in it. There are strategies that you see in Hannon. There are strategies that you see in the DIR, floor time model, because we really looked to see what evidence base there was before we selected strategies. But then, what we really wanted to do was not just come up with another intervention. That was not our goal. Our goal was there are a lot of these great interventions out there, but they're not being used. And in many cases, that's because there aren't really good provider preparation materials for it. For example, I said I worked with Dr. Laura Schreibman in graduate school in a lab where we were investigating PRT as a parent training program. And at the time, the parent training manual was like this paper thing with like kind of a cardboard cover that was really not at all helpful, and it's still the manual that's used. So basically, unless you go and work in a graduate lab where you are getting training, it's really hard as a provider in the community to just pick it up and do it. So really our goal was not to create another intervention, but was to take what we know about what are effective interventions and put it together in a way that's usable so that we can disseminate it. So in this process, like I said, it was a 5-year process. We worked really closely with community providers and parents to develop a structure and materials that would be really usable to somebody that maybe didn't have 5 years of graduate school training in a parent training research lab. So that somebody that had experience working with kids with autism and had some knowledge of intervention strategies could pick up the materials, maybe do some relatively brief training, and be able to effectively train parents. So I'm going to give you just a very brief overview of what this curriculum includes. We're not really going to talk a lot about the actual intervention strategies today. I'm going to talk a little bit more about the evaluation of the model. But just to give you an overarching view so you can kind of connect it to some of your other intervention models that you might be familiar with. This is a social communication intervention. So it really is designed for children in the early level or early stages of language learning from pre-verbal kids up to kids that are about the sentences stages. Developmentally, kids up to about 3 years, 3.5 years of language age. So most of the kids that have been in our study have been between the ages of about 2 and 8. And we target these key early social communication skills that are known to be impaired in this age range in kids with ASD. So we target social engagement, and that includes both dyadic engagement, face-to-face play between the parent and the child, as well as triadic engagement or joint attention, play around toys, turn-taking, that type of thing. We also target language and communication. We actually tend to go for a verbal approach for kids that are pre-verbal who are not yet making contingent sounds. We will back up and use gestures. We've actually chosen to use more of a natural gestures approach as opposed to specific signs, but it can be substituted out for signs if needed. We also target social imitation, so imitating others spontaneously within the context of play. And we also target expanding play skills, trying to expand the developmental level of play, so moving children from pre-functional to functional play, from functional play to symbolic play, as well as more socio-dramatic play that involves continued themes with a play partner. And I should say that this is, again, it's a parent-mediated intervention, so the play targets are typically play with a parent as opposed to play with a peer, although you could adapt some of these strategies for siblings or peers. In terms of the intervention techniques, most of you who have had experience with a naturalistic behavioral intervention before will notice a lot of these strategies sound similar. We put them in a pyramid because this is a parent training model, so we actually train parents sequentially. So we start with one strategy and add strategies to it to help facilitate parent learning. And we sort of talk about it in terms of a pyramid, which there are strategies that you use that serve the foundation of the pyramid. So these are strategies you should be using throughout your interactions with your child to increase engagement. If they're not successful, then you can move to the middle of the pyramid, and these are some strategies that are a little bit more likely to get a response if your child doesn't respond when you're using strategies at the base level. And then at the very top of the pyramid, we have the direct teaching strategies. These are naturalistic prompting and reinforcement strategies that are used within child-directed activities, and these are used to increase the complexity of the child's skills. And so you should only be using those about 1/3 of the interaction. And we teach parents to move up and down the pyramid based on the child's level of interest, based on the child's targeted skills, and based on the activity. So briefly, we start with following the child's lead, getting the parent to join in the child's play, letting the child select the play activities, and having the parent join them and letting the child choose how to play with those play activities. Imitating the child in terms of imitating their play with toys, imitating vocalizations, imitating gestures and body movements in order to encourage engagement. Heightened animation, so emphasizing facial expressions, vocal tone, gestures in order to try and increase the child's attention to the adult and to make the interaction more engaging. And then modeling and expanding language, so providing language that is simple and around the child's focus of attention. And then if these strategies don't serve to get the child to initiate with the parent, then we use strategies in the middle, playful obstruction, so playfully interrupting or blocking the child's goal so that the child has to attend to the adult, balanced turns, taking turns with materials, and then communications, so setting up the environment so the child needs to initiate, to get what they want, and then the top are the prompting and, as I said, prompting and reinforcement strategies. The next piece is the parent training model. So that is the intervention itself, and as I said, you can see those strategies seen, they are in many different naturalistic behavioral interventions that have been designed for parents or as just a direct intervention. We actually ended up having 2 different formats for training parents. And this is because our work with community providers helped us understand what models were and were not going to work in different settings. So we actually started developing this within a speech clinic. So we worked very closely with speech pathologists, occupational therapists, and psychologists who saw kids in a more traditional clinic-based format. So they saw children once or twice a week for a 50-minute hour. And so we developed a model that worked in that context. And that was 2 sessions per week for 12 weeks for a 60 or 90-minute session, which is really 50-minute, 75-minute hour. Parents would come in twice a week. The parent and the trainer would work individually with the parent while the child was present, but playing. They would do collaborative goal setting. All instruction would be done live. There'd be modeling, in vivo coaching by the trainer of the parent while the parent practiced with the child, and then assigned homework. And this model actually works very well in a clinic-based setting or even an in-home setting where the provider is going out to the home, working with family once a week or twice a week. But it doesn't work very well in settings where the children are being seen primarily in classroom settings. So we actually had to modify this so that this would be usable in early childhood special education programs. And so for that, we actually took the same content and moved it to more of a group model. So parents receive training in the concepts and the actual techniques during 6 group sessions where they actually receive information about the techniques in a more of a didactic workshop where they see videotaped examples as opposed to live modeling with the child, group discussion and homework. And then every other week, the parent comes in one-on-one with their child and gets coaching. So it's actually much less coaching, but the information being shared to parents is being done in a group format, and this is much more feasible for group settings. So what I want to talk a little bit about now is some of our research that we've actually conducted on this model. We think it's pretty important to identify not only does the intervention work the way you think does it work, but how does it work? And is it usable? So the first question we really had is, given that we're really trying to design a curriculum that can really be used by providers in the community, that we really want to disseminate this, we wanted to know whether or not our models were actually feasible for community-based intervention programs. And we actually had quite a bit of evidence from our individual training model that it works. There are actually programs that use parent training models when they see people individually. So we were particularly interested in our group-based model in the schools, because this is the area where we're really seeing difficulty getting classroom teachers to adopt parent training models. So we used the pre-post test design with 3 intermediate school districts in Michigan. When we did our data collection, it actually involved 13 different teachers who ranged from special education teachers to autism consultants to EI providers. There were 24 families involved, and the children were ages between 2 and 6. In terms of the trainer preparation, none of the trainers had had experience doing a particular type of parent training before. They had many of the EI providers had worked with families, but not in a systematic way. So we actually did an initial trainer workshop, a 2-day training to expose them to the intervention techniques and then also the parent training techniques. And then we provided technical assistance as the teachers implemented the program with their students and their parents. So we actually came out to some of the coaching sessions and gave them feedback, but we were not the ones providing parent training, it was the teachers that were doing that. And so we wanted to know, is this a feasible model? When we actually have the real people that we expect to do the intervention, can it be done, and what do they think of it? So we looked at feasibility and acceptability in terms of completion and attendance rates by the parents. And again, these are parents of kids in public schools. There were no pre-selection criteria. Everyone who was in the classroom could be enrolled, so we weren't recruiting like a special group of families that would be willing to come to a research lab. They were families receiving services in the public setting. And then we also asked the families and the teachers to complete a treatment acceptability rating scale. We also had both the parents and the teachers fill out a number of report measures, the social communication checklist, which we use for goal setting as part of our curriculum. This is something that we've developed. Some of my stuff is missing. Social responsiveness scale, the SRS, and then a measure of parenting stress, the PSI. And then finally, we observed the parents during an interaction in their home. They actually received the training in the school setting, but we did visit their home at the beginning and the end, and we videotaped a parent-child interaction, and we scored that for parents' use of the intervention strategies, or parent fidelity, and then we also scored it for child language use. So we're really looking here, if we train them in a school setting and coach them there, are they able to use these strategies at home with their child? So we were really pleased to see that 89% of the families that began the program completed it. Now this is a pretty high completion rate for parent-mediated interventions. And particularly high when we think we kind of had an unselected population. These were not people that showed up and said they were going to be part of a research study. They knew they were in a research study, but they were really there just receiving services for their child. Of the families that completed the program, 87% missed 2 or fewer sessions out of the 12 sessions we had, so we actually had a relatively good attendance rate as well. We also asked the parents and the teachers to fill out a treatment acceptability rating scale to look at whether or not the intervention we were providing was acceptable, because treatment acceptability is actually very, very closely tied to fidelity and to usage. So if people don't really think that treatment fits with their philosophy or fits with their program, or if they think it's hard to use, the likelihood that this is going to be continued to be an effective program is pretty low. So we actually had very nice agreement between the parents and the teachers. This was a 1 to 6 rating scale, with 6 being strongly agree, meaning that's very acceptable, and 1 being strongly disagree. So the program was rated high in terms of acceptability of the intervention strategies, perceived effectiveness of the intervention strategies, and perceived usability of the program. So how easy was it for the teachers to actually implement? How usable was the intervention for parents to implement with their children? And parents also reported that they experienced some increased social support, and that they actually had an improvement in the relationship that they had with their child's teacher, which is nice, because a lot of these parents have actually had their kids in the teachers' classrooms for a number of years. So this suggests that when parents and teachers work closely together, they actually can improve that relationship. Then we looked at some of the parent-teacher report measures, and we actually saw some really nice improvements from pre to post in parent and teacher reported social communication. Oh, sorry, that's the parent and teacher. We also saw a significant decrease in teacher-reported autism severity in terms of social responsiveness, but not for parents, just for teachers. And then we also saw a significant decrease in parent-reported stress, both in the child and parent domain, which was really nice because it was a relatively short-term intervention. So this does suggest that, at least from these report measures, parents are perceiving their children as gaining skills, and they're also reporting less stress in relation to their child. These are all report measures, though, and they tend to be a little bit biased. So we actually went into the families' houses, and we actually looked to see, are the parents using the intervention with fidelity? And we saw a significant increase in the parents' use of the intervention strategies, which is what you would expect. And in our lab, a overall rating of 4 or above is considered meeting fidelity. So they were just, the average parent was just barely, not quite meeting fidelity, but that's the fidelity rating we give for professionals using the intervention. So it suggests that most of our parents were actually learning to do the intervention with close to fidelity. So this is very encouraging because we were training teachers who were then training parents. So this was a better finding than we were expecting. We were thinking that there would be a lot of loss of fidelity along the way. And we also looked at child use of language, and we found significant increases in the amount of language that children used with their parents, both during a play interaction. So we said, play with your child as you usually do, and we filmed them for 10 minutes. And then during a home-based routine, we asked the parents to have a snack with their child and do what you normally do. So the children were using more language both in that play interaction as well as this home-based routine. And this is really nice because we teach them with it. We teach them all sorts of strategies to carry out during daily routines, but we actually, since we did the training in school, didn't actually coach them doing it within daily routine. So this does suggest that there is some generalization of skills from play to other daily routine activities. So kind of the conclusions of this initial study was that mainly the group model is feasible for implementation in EI, ECSD settings. So this suggests that if indeed we get better evidence to suggest this is an efficacious model, this does seem to fit pretty well with the way providers want to provide intervention or are able to provide intervention, which would suggest that this is going to be hopefully encouraging providers to actually adopt parent-mediated interventions more. We had low attrition, high acceptability, and improvements in parent fidelity and child social communication. We also saw some decreases in parenting stress, which again suggests that this is something that might have broader family effects, which is very nice. Now, this was great. It was a great initial study. We were very pleased, but it was a one-group pre-post-test design. So some of these things could be due to just change over time. We didn't have a control group. So really there's a need for more controlled designs to really understand and test this model to make sure things are working in the way we think they are. In addition, we didn't collect much information on how the providers implemented the model. We looked at parent fidelity, but we didn't look at trainer fidelity. So we need more evidence to understand how we train providers to do it and how providers are trained parents. There's kind of multiple levels involved. And then finally, we know that if we can even make the assumption that it is our training that's improving parent fidelity, so say we make that assumption, and it is our model that is improving child language, we still don't really know how it's working. Is it because parents are using specific strategies with their children? Is it that? Is it the intervention? Is it because parents are feeling more competent in being able to interact with their child? Is it because parents are spending more time with their child? Or maybe the parent is focusing more on social communication development that they wouldn't have paid attention to before. So not only is it, we know that, even if we make the assumption that the model works, we're not really quite sure how. So we need to do some additional research to figure out what is it that the parents are doing that are leading to changes in their child behavior. So one of the ways we thought we would do this is, because it's a parent training model, there's a lot of stuff going on. There's the intervention that's used with the child, and then there's the parent training model that's used with the parent. So we figured it's really hard to figure all of this out in a single design. So the first step is to actually look at this intervention model by itself, the intervention package, the techniques we're teaching to parents, and see if those techniques by themselves indeed increase child skill. Now we have every reason to think that they would, because we selected them based on our knowledge of the literature. But nobody's actually combined them the exact way that we combined them, and so we really needed to test this out to understand which pieces of the model are working. So in this case, we did a single subject, multiple baseline design. Are people familiar with this type of research design? Okay. Basically, just for those of you who are not, it's you have very intensive multiple observations of the participants over time, and each subject serves as their own control. So rather than having a group of individuals that get a treatment and another group that doesn't and comparing them that way, you have a small number of individuals who get no treatment and then treatment, and you compare their non-treatment behavior to their treatment behavior. So in this study, we actually had 9 kids. We had a multiple baseline design, and during baseline, we had therapists play with the children. They showed general responsiveness to the child's behavior, but they weren't actively trying to engage them using intervention strategies. So they would comment on the child's play, and they would ask questions every 30 seconds, and then they'd model an action for the child to imitate, but they didn't really follow through in any other way. Then they had treatment where they used this pyramid of intervention techniques together, blended, and for 5 of our kids, we did this twice a week for 1 hour, twice a week for 8 weeks. For 5 of the kids, they got 30 minutes focused on language and 30 minutes focused on play skills. And then for 4 of the kids, we targeted them both for the hour. So we wanted to know whether or not focused attention to language and focused attention to play was different from blending and targeting multiple skills concurrently. We did generalization where we had therapists, settings, and materials that the child was not exposed to during training to look to see whether or not the children generalized to new settings, therapists, and materials. And then we had a 1-month follow-up where we brought the kids back 1 month later and examined how they did. And then in terms of our data analysis, we used visual analysis of the session data, visual inspection, which is what you typically do with single subject designs. But we also wanted to aggregate across these kids, since we have a lot of kids in the sample for a single subject design. So we actually use multi-level modeling to actually aggregate across kids and see, are there general patterns? So this is just a very brief, I don't expect you to read all this, but the things I just wanted to point out here is we had kids ranging from 2 to about 8, if I can do my math correctly. We had, most of their nonverbal mental ages was in the kind of 2-year age range, although we had some kids who had a little bit more skills. Although you can see they all had a pretty significant language delay. And in terms of the sort of their functional language use, they range from being pre-verbal to being at the sentences phase. And so we also had very specific language targets for each of the kids, and they're denoted up here. So these are based on the degree to which kids increase their specific language targets. So the way we actually looked at the data was single subject design. So we actually would stack these up, and we had 9 of them, and we would look to see for shifts between baseline and treatment. I will not present it to you that way because your eyes will cross if you try and stack them on a PowerPoint presentation. Once you get past about 3, it's really hard to look at. But just to show you that we did our data analysis this way, and this is an example of a little guy, Tony, that I'll show you a brief video clip of in a minute. He had no language during baseline of any sort. Oh, I'm sorry, I don't have the thing in there. The light green is spontaneous language, and the dark green is prompted language. Then with the onset of treatment, we see a nice change in his trajectory, particularly for prompted language. Towards the end of the 8 weeks, we start seeing spontaneous language picking up a little bit. Not sure quite how to interpret that. And then a nice maintenance of his prompted language at follow-up. So aggregating across children using our multi-level models, we saw really nice improvements in prompted language and significant improvements in spontaneous language, but they were not as impressive. The nice thing was that even after a month, not only did we see maintenance of skill, which of course you want to see, but we actually saw the kids continue to improve. And this actually, unfortunately, is not always what you get in autism interventions. For targeted skills, oftentimes what you'll see is really nice increases, you stop working on it, they come back, and it kind of declines. But we saw an actual continued increase, which is very nice, suggesting that the skills they're teaching them in terms of language are actually starting to have a transactional effect and starting to roll forward. We also looked at social engagement, and we found significant increases in social engagement, again, between baseline and treatment, but then, again, increasing even more at follow-up. I thought I would show you just a really brief example, because whenever I see somebody else talk about research on treatment, I want to see it in my head, like I want to know what I'm actually looking at. So this is just a very brief clip of this little guy, Tony, the one who I showed you single subject design data for. He came in completely nonverbal. He didn't even make contingent sounds. So you're going to see him, oh, that should say week 2, I'm sorry. This was at week 2, then you'll see him at week 8, and then you'll see him at week 12. So you can kind of just see a little bit of the intervention. You can also see sort of how his language was progressing.
Over here, we have blocks. Relax. And open. Say open. You can do it. Open. Let's wait. Open, Nikki. Open. Good job. Nice pointing. Open, blocks. Open, blocks. Don't go out. Don't. Don't. Out. There you go. Out, 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 out. Blocks. Orange and green, come out. It's empty. All out. The bag. Bag. Oh, zip. Zip. Oh. Close it. You want to close it. Blocks. Blocks. Stack. Blocks. Turn it around. Around. Okay, turn around. On. Push. Turn it around. You put it on. Good. On. Nice job. On. Look at it so tall. Look how tall. Turn around. On. You like it so tall. What should we do? Oh, one more. Turn. Let's turn. On. Open. Open. Good job. Open. Marbles. Marbles. Oh, so many. You like a lot of marbles. Ready, set, go. Go. Pop. 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 Good asking. Open. Open fish. Fishy swim. Big fish. Dump. Fishies. Red. Red fish. Oh, that one's a seahorse. Fish. Fish. I'm gonna catch one. Caught it. Red. I'm gonna catch one. I caught it.
So just as an example, so you can sort of see what the techniques are and sort of how we saw improvement over time. Of course, this is a child that responded very nicely. We had some kids that responded similarly. We had some kids that continued to struggle to use a little bit more language. But these are really good example of a child who started. So then the next question we had is whether or not the parent training model is efficacious. So basically what we know is the intervention components. Based on this study, I mean, clearly more studies would be helpful, but we know that the intervention that we're teaching parents in and of itself is effective for increasing language skills and in social engagement. And then we're currently looking at imitation and play, but we're still coding the videos, so we would hope that we would see changes in those skills as well. The next question is how we're training parents efficacious. Are parents increasing their skills? So we again used a single subject multiple baseline design. During baseline, we had parents play with their children as they typically would. Then we conducted the intervention. And as I mentioned before, our program was designed to be done twice a week for 12 weeks. This is the individual model. But what we were actually finding, this gets to this issue of sort of transportability or getting community people to adopt a program, is we found a lot of people saying, yeah, but I can really only do it once a week. Does it work once a week? And we had some ideas that it might, and we gave some suggestions about how you could lump different topics together. But we don't actually know. Does parent learning differ whether you're doing it twice a week or whether you can do the same amount in once a week? So we actually had 5 families that did it twice a week and 3 families that did it once a week. We looked at generalization in the families' homes during play and during the snack routine, and then we had the families come back 1 month later. And again, data analysis was done similarly. Brief overview of child participants, similar. Although the one thing I'll point out is actually we weren't doing random assignment, but kids were kind of randomly put into groups as they kind of came into the program. And we couldn't really compare language learning between the kids, between the group, between once a week and twice a week, because we had more lower level language kids in the once a week. So, but we could look at parent learning. One thing to note is there was no difference in parent learning between once a week and twice a week. So this is really good. This means we can take the same model and we get the same amount of parent learning, same increase in parent fidelity once a week as we do with twice a week. So even though our manual is set up to be done twice a week, you can do it once a week and we feel pretty good that parents will still learn it. As I said, we don't know about child learning though, because we couldn't really compare the groups because they were just not comparable. We had nonverbal, pre-verbal kids in the once a week and kids that were at the sentences stage in the twice a week. So it's just, that's not a good comparison, but I think that needs to be looked at also. So when we collapsed across the 2 different ways of delivering it, we saw significant increases between baseline and treatment, and then not only maintenance, but actual continued improvement and follow-up. So that's always a concern with parent-mediated interventions, that the parents drop off over time. But at least with a 1-month follow-up, things still stayed nice. Interesting here, in the first study we saw really nice improvements in prompted language, and the spontaneous language wasn't so great. Here, we actually didn't see changes in prompted language. Partly because parents were prompting their kids constantly during baseline. What's this? How many do you have? What color is this? Show me this, tell me this. So the way we coded prompted language, even though the parents learned to do prompts better, and the language that they were getting was probably more along the lines of what we would want to be conversational, the way we coded it actually didn't show us a change. But more excitingly, what we saw were really nice changes in spontaneous language, which is what we actually want. And we saw, again, this really nice pattern of continued improvement and follow-up, suggesting over time, not just when the parents learn it, but over time their kids are continuing to get better as they are using it more with their kids. So I thought I would show you just a very brief video example of the kind of changes we wanted to see both in the parent behavior and the child behavior. And this is an interesting example because I'm going to show you baseline with the mom playing with her daughter. And then I'm going to show you an example of her in treatment. And this is actually really early in treatment. So this is not that the child has had many, many weeks to develop skills. She had a lot of these language skills. But the interaction patterns between the way the mother was working with her was somewhat suppressing that. So I wanted to sort of let you think about this too. So I think that actually the treatment is only about 3 weeks into treatment. Oh, it's going to do that to me here too. Okay.
Come Michaela, look. Mickey, look. Look what mommy's doing. Look, Michaela. What are you gonna do? Are we gonna cook? Let's turn on the stove. What are we cooking? Let's get a frying pan here. We're gonna fry some chicken. In the frying pan. What is it? Look, Michaela. Cook chicken. Cook chicken for the baby. Cooking the chicken. Michaela, can you wash the plate? Can you wash this plate for the baby? Look, wash the plate. Wash the plate. Wash the plate. Now we're gonna eat some chicken. Let's feed the baby some chicken. Come on. You're gonna feed the baby? Give the baby some chicken. Chicken? Eat, baby. Eat some Some chicken? Good job.
Mommy, a chicken.
Chicken for the baby? Chicken? Michaela, I think the baby's thirsty. Can the baby have something to drink? Give the baby something to drink. Drink? Can the baby have something more? Can the baby have more drink? More juice for the baby? More juice? Can the baby have some more juice? Let's get some more juice from the refrigerator. Cookies? Mickey made a cookie. Mommy's gonna make a cookie.
Meow, 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 meow.
Yummy cookie!
Yummy cookie.
Yummy cookie! I have a cookie. Mommy's cookie and Mickey's cookie.
A cake.
A cake? Michaela has a cake. Mommy has a cake. Ooh, yummy, yummy in your tummy. Yummy cake. An orange cake. Is this an orange cake or a yellow cake? Ooh, delicious. Delicious. Now I'm thirsty.
I want some juice.
You want some juice? Delicious.
Drink.
Drink. Thank you, Mickey. Thank you. Thank you, Mommy. Squeeze, squeeze. Gonna make another cookie.
He's a cake.
It's a cake. That's a pretty cake.
So similar type of activity, but just changing the interaction strategies that the parent was using. Mom was working so hard at the beginning. And just by changing some of those basic interaction strategies, you could see how the child's skills were actually able to come out. And so that's one of the things that is really, I think, exciting, because not only that, you can also see the mom is working more relaxed. So this is where we see some of those changes in stress coming out. So finally, I just want to make one mention, which is one of the things we were actually able to do because we had a single subject design, was to see whether or not it was actually parent use of intervention strategies that were actually leading to changes in child language. So we actually did a multi-level model, and we looked at correspondences between the parents' use of four different fidelity ratings, four sets of strategies. You know, I said we had the triangle of these different interventions. Like, what were the intervention strategies that were related to changes in the children's language? We actually found making play interaction active, which involved following the child's lead, imitating the child, and being animated, was significantly associated with spontaneous language, and increasing the complexity of initiations, which is naturalistic prompting and reinforcement within the conduct of child-directed activities, was also related to increasing the spontaneous language. And these other two, which we think of as important, modeling language around the child's interest, as well as playful obstruction to encourage initiations, neither one of those actually were related. I think the encourages initiations might be because that's kind of part of appropriate prompting. So if you weren't actually adding in the good prompting, you weren't getting the spontaneous language. But I think this tells us a little bit about what are these pieces in the intervention that are actually leading to change, and it does have to do with specific things that parents are doing. So just in general, I want to conclude with, one, we have an intervention model, parent-mediated intervention model that's feasible for use in community-based settings. It also appears that the intervention techniques are effective for increasing social engagement in language, and hopefully we'll find out more about imitation and play. And we know that multiple targets can be taught simultaneously, and we also can see that this was done at a really low intensity, so twice a week for 8 weeks, and we got significant changes in social engagement and language. So although we really were testing it to find out if it's part of the parent training model, it also appears it could be used as a low-intensity treatment in speech clinics and one-to-one therapy that may also have some meaningful effects. And then finally, we found that the parent training model is effective for increasing parent use of the intervention techniques, and that it can be modified to once a week without loss of parent fidelity, and that several specific strategies that we teach the parents are directly related to changes in child outcomes. So we're very excited about this, and we are planning to look at this in more controlled ways with larger randomized controlled trials, going out to doing some effectiveness studies in the community. Those are our long-term next steps. So I have taken you long, I'm sorry.
Sorry. We probably have a few minutes for questions.
Absolutely, I can stay. If you guys need to leave, I will not be offended, but I'm fine to stay. So questions?
I actually thought it was really compelling in your mixed effects analysis that it was not, that what turned out to be significant, because when I saw it, it seemed a lot like parent-directed interaction in PCIT to me, what had changed with her. How specific do you think the things you're teaching the parents are to the language issues that kids with autism have, as opposed to language issues that kids with language delays have?
Oh, if you're coming at this kind of like from a verbal behavior perspective, we do not focus on that
Okay.
at all. We basically are trying to increase the rate of the children's communication. It's mainly we teach them to do language modeling with the theory that that should increase things like receptive language and provide models. And then we do direct prompting, typically within the context of the child's interests. So it's usually teaching requesting. We don't typically prompt for we do prompt for labels, but the reinforcer is access to the materials, which I know the VB program would say is not truly teaching labeling, because the reinforcer is actually directly related. So we all teach it within a direct response reinforcer relationship.
But on the other hand, I think maybe it has some applicability to a much broader population.
Yeah.
Like a year or two ago in the news, there was a lot of talk about the language enrichment of kids who end up being behind in the early school years. Kids who are developmentally grossly normal, but end up behind. And this might help parents essentially talk so that the kids will talk more.
Absolutely. I mean, and it's really funny if you look at things like PCIT, the theory as to what you're doing and why is totally different.
Right.
You're trying to increase the reinforcement value with the parent, right? But what you're actually doing until you get to the compliance training, that early parent-child interaction stuff, it's the same as you see in responsive teaching. It's the same as you see in DIR. It's the same. There's not as much focus on specifically simplifying language or eliciting language. But a lot of these kind of early sort of turn-taking, sit back and talk about what your child's doing, don't give directions, is very, very similar. And I think it's because across multiple fields, people are starting to see what works. Yeah.
I have two questions. I noticed on your website that you're working with some local school districts.
Yes.
And I wondered if that's all research-oriented or if you have a different role with those districts. And then I have another question.
We do have a different role with those districts. So we also do training. So one of the things that I like to think of this in terms of research. I don't want to train people to do things that we don't have evidence for. But given that there are national guidelines suggesting you should be doing parent-mediated intervention, and there aren't good models out there that are easy to implement, we also have been disseminating as well. So we do training and we do work with local districts just to help them implement it.
And then my other question was, you said you're using a verbal behavior perspective? So
No, we don't.
Oh, you don't?
We don't.
Okay.
We use a more of a naturalistic behavioral perspective, so what you would see with PRT, where they're not really distinguishing between mans versus tax.
Okay.
We just happen to know that early language training typically focuses on mans. So this would be similar to enhancement of teaching and a lot of these other programs. Or like maybe the net piece of verbal behavior.
And where would we find the manual or packet or something?
Oh yeah, I can give you, you can buy it online at Guilford. And if you're interested in buying it, there's the manual, the trainer manual comes with a parent manual, but you can also buy the parent manual separately. And if you actually, when you go to their website, I don't actually have this on here, but the manual is called Teaching, let's see if I can find it. This is embarrassing, I'm not even sure what it's called. Because we call it Project Impact, but.
That's the Teaching Social Communication to Children with Autism.
There we go, yes. Teaching Social Communication to Children with Autism. And if you go to the Guilford website and look it up, if you put in the code 2E, you can get a 15% discount. So if you're going to buy it, get a discount.
And is your team still doing on-site trainings in 2013 in Lansing? Because you had some
Yes.
things in the
So
past.
we will be doing a training, we haven't set the date yet, but the way we've done it this round, and I liked it this way, and I think I'll continue to do it this way, is a 2-day training on the intervention, and then a brief, like several-month period for people to go back, feel very comfortable implementing the intervention directly with kids, and then they come back for a 1-day training in August to get trained on the parent coaching model. So it'll be in May and August, 2 days in May, 1 day in August, and we have not set the dates yet. But if people are interested, I can put you, like if you want to give me your emails, I can put you on our email update list. And at this point, we're really just doing kind of exposure training. I know that there have been some programs that have been interested in getting sort of follow-up coaching to get people up to fidelity, and we're kind of trying to figure out an approach for getting people, and we haven't done certification because it's kind of very early in that stages, but so that people feel like that they as a trainer really meet fidelity.